Clonus is ubiquitous in a neurologic rehabilitation population. It can be from mildly irritating to so violent that it shakes a patient out of their wheelchair or bed, or even lead to fractures and violent movements. It's a central nervous disorder, but can we stop it with a peripheral nerve approach? Is that even possible? We are presented here with a young man that was referred to the clinic with a spastic ataxia. You can see here he has spasticity of the left leg, and with the leg extended with the gastrocnemius engaged, he has quite a bit of clonus. When we bend the knee, which is difficult because of stiffness in the quadriceps, you actually see that the clonus is present but less. We surmise it's coming more from the gastrocnemius than the soleus muscle. When we proceed to the right side, you can see that there is sustained clonus again in the leg, interfering with his function. And when we bend the knee, there's still some clonus affecting the soleus in this leg, showing that that pattern and loop seems to have both gastrocnemius and soleus. Here we decided to perform a diagnostic nerve block using 1.5 cc's of lidocaine to the gastrocnemius medial and lateral branch. The clonus was obliterated. We did that in both the stretch position and the bend knee position, and he has no more clonus. This is something that does not happen to him without just that little bit of lidocaine under a peripheral nerve block. On the other side, again, it is obliterated with the nerve block, and this time we did the whole trunk because we wanted to take out the gastric and the soleus, and there is no clonus. With the knee bent, you can see it happens again. This patient had an unusual presentation of clonus because it affected the whole lower extremity. After the diagnostic nerve blocks, you can actually see he continues to have clonus in his thighs, a very unusual pattern. We surmise that it is possible if we block the clonus in the lower extremities, there will be the ongoing outflow affecting the quadriceps. So the question is, how do we best manage this patient? We will likely repeat the diagnostic nerve blocks a few times to see how it affects his ability to stand. He is not actually mobilized in several years, and we're sending him for therapy first, and we can repeat it. We may also consideration of a baclofen pump to affect the whole lower extremities. That image showed the arrangement of the medial and lateral gastrocnemius branches. Here we show an example of doing a block to the lateral gastrocnemius branch and going over to the medial gastrocnemius branch. It can be done by withdrawing the needle and placing it back in, or in many situations you can actually stimulate the one head of the gastrocnemius, pull back, and stimulate the other. If we were going to do the whole trunk, we just go more proximal, and the nerve in that case is nice and round and easy to see. We can therefore choose which branches we want to do without too much difficulty with proper ultrasound guidance and e-stimulation.